بسم الله الرحمن الرحيم. I'm Dr. رانيا محمد بهريز, lecturer of diabetes and endocrinology, Mansoura University. Today, I'll discuss with you the topic hyperparathyroidism and hypercalcemia. First, we must know a normal serum calcium. Normal serum calcium is from 8.5 to 10.2 milligram per deciliter, and it is classified into ionized calcium, which is 50%, and non-ionized calcium, the other 50%. For ionized calcium, it is the active form for serum calcium, while a non-ionized is in the form of protein bound or calcium complexes in bone and teeth. For the control of serum calcium in this level, there are several factors. First and the most important is parathyroid, which is secreted from the parathyroid gland, which are 4 in number and embedded behind the thyroid gland. Parathyroid act by increasing the calcium level in blood, and on the other hand decreasing the phosphorus level. It forms its action by acting on the intestine, the kidney and bone. On intestine, it increases the calcium absorption through its role on the activation of vitamin D. In the kidney, it increases the calcium reabsorption and decreases the phosphorus reabsorption. On bone, it increases the osteoclastic activity by stimulating the osteoclastic cells, so increasing the bone resorption, increasing the serum calcium. Second, the vitamin D. Vitamin D, its main source is from the sunlight. Vitamin D also has impact to maintain the calcium level in this range by acting on the intestine and the kidney and the bone. Its action on these organs increase serum calcium and increase serum phosphorus. Or intestine, it increase the calcium absorption. On kidney, small dose cause phosphorus retention, while large dose cause phosphorus excretion. On bone, in normal bone, it causes resorption and increasing serum calcium, but in case of rickets, it helps the calcium deposition. Third factor on calcium level in blood is calcitonin. Calcitonin is a hormone secreted from the parafollicular cells or C cells of the thyroid gland. Calcitonin, on the otherwise, decrease the calcium level and decrease the phosphorus level in blood. It acts by decreasing the osteoclast bone resorption and increasing renal excretion of calcium and phosphorus. Other factors which also has impact on calcium level but less important than the parathyroid, the vitamin D and the calcitonin are acid-base balance. Acidosis increase the ionized calcium, alkalosis decrease the ionized calcium. For glucocorticoids or steroids, it decrease the calcium and the phosphorus absorption, causing steroid-induced osteoporosis. For thyroid hormones, hyperparathyroidism decrease the bone mineral density, causing osteoporosis and increasing the calcium level in the blood. Also, growth hormone has impact on the calcium level. If there is growth hormone deficiency, there will be decreased calcium level in blood, as growth hormone acts on the bone mass through insulin like growth factor 1, and also it has a role in the stimulation of vitamin D, which is essential for calcium absorption by gut. Sex steroids like estrogen and testosterone also has a great role in bone formation by direct effect on osteoblast. So if there is deficiency in estrogen or testosterone, there will be bone resorption. PTH related peptide, which is produced by some malignant. The second part of our lecture is hyperparathyroidism. Hyperparathyroidism means hyperfunction of the parathyroid gland, and as we said before, we have four parathyroid glands embedded behind our thyroid gland. So it means abnormal increase in the parathyroid hormone, which is secreted from the parathyroid gland. Hyperparathyroidism may be primary. Primary may be due to sporadic solitary adenoma from 80 to 85% of cases, multiple gland hyperplasia in about 10 to 15% of cases, or parathyroid carcinoma for about 1% of cases. Another type of hyperparathyroidism is familial, which may be due to genetic predisposition and run in families. It may be due to multiple endocrine neoplasia type 1, which is also called MEN type 1, which includes hyperparathyroidism with pancreas and pituitary neoplasms. Second, multiple endocrine neoplasia type 2A or MEN 2A, which includes hyperparathyroidism with pheochromocytoma and thyroid medullary carcinoma, or familial hypocalciuric hypercalcemia, which is a syndrome in which there is decreased calcium excretion by the kidney. So this causes increase in calcium level in blood. It is characterized by hypocalciuria, mild parathyroid elevation, and mild hypercalcemia. Third, there is tertiary hyperparathyroidism. Tertiary hyperparathyroidism occurs following long-standing secondary hyperparathyroidism. So, what is secondary hyperparathyroidism? Secondary hyperparathyroidism occurs in cases of chronic renal failure or malabsorption due to hypocalcemia, which cause feedback increase in parathyroid secretion from the parathyroid gland. This long-standing secondary hyperparathyroidism will lead to the development of autonomous adenoma in the parathyroid gland and become tertiary hyperparathyroidism. For the clinical picture of hyperparathyroidism, in primary, the patient usually is asymptomatic and the hypercalcemia is detected by routine biochemical screening. If there is symptoms and signs, it will be of hypercalcemia. Renal manifestations, usually in the form of polyuria, polydipsia, nephrolithiasis, nephrocalcinosis, nephrogenic diabetes insipidus, renal tubular acidosis. For neuropsychiatric manifestations, there may be lack of concentration, confusion, stupor, and coma. For gastrointestinal, most important may be peptic ulcer, pancreatitis, and constipation. For musculoskeletal manifestations, there may be muscle weakness, bone pain, and very important osteoporosis, and what's called ostitis fibrosa cystica, which is pathogenomic for primary hyperparathyroidism. Cardiovascular manifestations like hypertension, bradycardia, and shortened QT interval. For the diagnosis of primary hyperparathyroidism, we will see elevated parathyroid hormone level, hypercalcemia, hypophosphatemia. By isotopic scanning, an adenoma may be detected. By bone scan, there will be ostitis fibrosa cystica, which is commonly found in the jaw, cystic lesion in the jaw, which is called epulis. By DEXA scan, osteoporosis may be found. By X-ray on the kidney, there may be kidney stones or nephrocalcinosis. And also, in all cases, I must exclude men by causing other or requesting other hormonal essay. In differential diagnosis or differentiating different types of hyperparathyroidism, in primary hyperparathyroidism, the patient usually asymptomatic with chronic mild hypercalcemia in a post-menopausal woman with normal physical examination, with no family history of hyperparathyroidism and no evidence of multiple endocrine neoplasia. For secondary hyperparathyroidism, patient usually is a patient of chronic renal failure on dialysis or a patient with malabsorption syndrome, and by laboratory investigations there will be hypocalcemia with elevated plasma BTH. For tertiary hyperparathyroidism and familial hyperparathyroidism, in tertiary hyperparathyroidism is also usually a patient with long-standing secondary hyperparathyroidism, as we said, in a patient with chronic renal failure or malabsorption syndrome, which have chronic decrease in serum calcium level. In familial hyperparathyroidism, there will be decreased calcium excretion in 24-hour urine collection. And lastly, I must exclude all other causes of hypercalcemia. For treatment of hyperparathyroidism, first I must lower serum calcium, and will be discussed later in the treatment of hypercalcemia, and I must treat the cause, which is surgical removal of the adenoma in primary and tertiary hyperparathyroidism and multiple endocrine neoplasia. The third part of our lecture is hypercalcemia. Hypercalcemia, which means calcium level above 10.2 mg per deciliter. Hypercalcemia usually results when the entry of calcium into circulation exceeds the excretion of calcium into the urine or deposition in bone. Hypercalcemia may be classified into causes which increase bone resorption, like primary hyperparathyroidism, tertiary hyperparathyroidism, any malignancy which secrete local osteolysis or osteoclast activating factors, thyrotoxicosis, immobilization, Paget disease of bone, patients taking anti-estrogen like tamoxifen, and any patient with hypervitaminosis A. Causes which increase calcium absorption, like increased dietary calcium intake, excessive calcium supplementation, milk alkali syndrome, or hypervitaminosis D, as in patients taking vitamin D fortified milk or calcitriol in high doses. Also, the causes of hypercalcemia may be classified according to BTH into BTH mediated hypercalcemia and BTH independent hypercalcemia. For BTH mediated hypercalcemia, it includes primary hyperparathyroidism, sporadic form, familial, men type 1, men type 2A, and familial hypocalcuric hypercalcemia, and tertiary hyperparathyroidism. So it's the all types of hyperparathyroidism except secondary hyperparathyroidism. PTH independent, like hypercalcemia of malignancy, vitamin D intoxication, granulomatous disorders like TB or sarcoidosis. Some medications from its side effects is hypercalcemia like diuretics, which is usually combined in anti-hypertensive drugs. Lithium, excessive vitamin A intake, and thiophanate toxicity. There are endocrinal causes which may be associated with hypercalcemia, and it's important for you to know it, like hyperthyroidism, acromegaly, pheochromocytoma, and adrenal insufficiency. There may be hypercalcemia in these endocrinal disorders. Also, parenteral nutrition and milk alkali syndrome predispose to hypercalcemia. For the clinical manifestations of hypercalcemia, in mild hypercalcemia, it may be asymptomatic or non-specific symptoms like constipation or fatigue or depression. In moderate hypercalcemia, more marked symptoms like polyuria, polydipsia, which may cause dehydration, muscle weakness. In severe hypercalcemia, which is defined as serum calcium above 14 mg per deciliter, there is often progression of these symptoms. For the diagnosis of a case that it is hypercalcemia, we must repeat sampling to confirm that the patient has hypercalcemia. And if there is hypoalbuminemia, I should correct its serum calcium for albumin by a certain equation. You can search for it and see it. Additional lab data may be done with serum calcium, like serum protein electrophoresis, for possible diagnosis of multiple myeloma. Multiple myeloma is a malignancy which is common in elderly and may present with hypercalcemia. Also, TSH should be done to exclude hyperthyroidism. Also, I must keep in my mind familial hypocalcuric hypercalcemia, which is diagnosed by calculating urinary calcium excretion. In radiological investigations, the presence of ostitis fibrosa cystica in bone films is very specific, as we said before, for primary hyperparathyroidism. For the treatment of hypercalcemia, in mild hypercalcemia, adequate hydration or adequate water intake from 1.5 to 2 liters of water per day is recommended to minimize the risk of nephrolithiasis and renal stones, plus treatment of the cause of hypercalcemia. For moderate hypercalcemia, also treatment of the cause, and it may require more aggressive therapy, as it will be described in severe hypercalcemia. In severe hypercalcemia, volume expansion by isotonic saline, calcitonin hormone, which is given in the form of a nasal spray to decrease the calcium level in the blood, bisphosphonate, which is given especially in cases of osteoporosis to decrease the bone resorption, glucocorticoids or exogenous steroids, especially in cases of lymphoma, sarcoidosis, and other granulomatous disease. Finally, dialysis in severe life-threatening cases of hypercalcemia not responding to the previous measures. And thank you for listening.